So our first speaker today will be Kfuri talking about alternative digital planning.
So good morning, everyone. We're going to talk about digital planning, preoperative planning. Thank you very much for having me today. So basically, I'm going to share with you some of my experiences using one particular platform for preoperative planning. Before I start, let me acknowledge the contributions of three of my colleagues from Germany, Dr. Herrer, Dr. Schroeter, Dr. Lobenhofer. We've worked together for many years in preoperative planning sessions and courses, and some of the contents of this talk are related to things that we've shared together during the last years. So the learning objectives for this presentation are: at the end of this session, the learner will be able to request appropriate long leg standing radiographs for preoperative planning, understand the principles of coronal alignment measurements, identify the landmarks utilized in the preoperative planning of lower extremity deformities, and recognize the value of digital planning for 3D evaluation of deformities. The first thing is the long leg standing radiograph. It's a critical thing that we take it right. So this is a patient of mine, 6 weeks after surgery. I've done a varus producing osteotomy, a medial closing wedge for the left lower extremity. And when I requested the postoperative alignment, this is what I got. I said, oh my gosh, what I've done here. Is this an overcorrection? Then I said, let me look with more details. Let me get new pictures. And I repeated the same radiographs again, the first day, the same day. And you see, it does not look overcorrected at this point. So how come? What's the difference? What's the magic here? So let me share with you. You have to look at three things when you ask for a long leg standing radiograph. Where is the patella? Where is the tib fib and the ankle? And you have to look at the condyles of the femur as well. The three things are critical. In this particular case, the leg was externally rotated. You see there is a huge overlap of the fibula. You barely can see the fibula in this case on your left side. And then you can see on your right side that if you do a turn or if you rotate the leg, so the patella is going to be facing the X-ray or the beam, and you're going to have 1/3 of overlap of the fibula. This is what you expect for a very good quality X-ray. Again, what shall we look at? You have to look at the fibular head overlap. It should be 1/3 of overlap in the tib fib. You have to make sure that you're having a perpendicular view of the condyles, that the condyles are not oblique, that the patella is looking to the front. The other thing, on the other side, if you look, this is a bad X-ray. No overlap of the tib fib joint. You don't see the condyles very well. They are asymmetric. And you see the patella is not centered. So if you use this picture to plan, you're not going to have a very precise measurement of the angles. And this is what you should know when you do those plannings. Be careful with the pathology as well. If the patient has patellofemoral dysplasia, or if the patient has recurrent patellar dislocation, you have to be careful, because if you try to center the patella in those patients, take a look to what happened to the tib fib joint. There is no overlap of the tib fib joint. This tells you that this leg is rotated, and then again, you cannot be precise in your measurement. So patella in the center is not always the answer. Took a look again, the same patient. If you have the patella centered, and if you don't have the patella centered or lateralized in that way, but if you take a look at the pathology, which is patellofemoral dysplasia, in this case, you don't look at the patella only, but you look at the tib fib joint, and you see very different angles, very different measurements in the coronal plane. So you have to know what pathology you're dealing with before taking those X-rays as well. The other thing is leg length discrepancy, because it does matter. Like if you have a leg length discrepancy, you're going to have a pelvic tilt obliquity of the pelvis. And if you want to get very precise measurements for the coronal plane, you have to level the lower limbs in the way that you're going to have your knees not necessarily at the same level in the x-rays, but the pelvis has not to be tilted, it has to be leveled. The message number one of this presentation: long leg extending radiograph may be compromised by rotation of the lower limb, leg length discrepancy, and the primary pathology, especially if you're dealing with patellofemoral dysplasia. Alignment in the coronal plane. The mechanical axis of the limb is the Mikulicz line, or the line that connects the center of the hip to the center of the ankle. And this is a very critical line for the alignment of the lower limb in the coronal plane. And again, if you see where this line is crossing the knee, then you have a sense about this deviation of the mechanical axis in relationship to the center of the knee. This is what we name mechanical axis deviation. And it could be a deviation towards shifted to the medial side, which is a varus, or to the lateral side, which is a valgus. And this deviation is a critical thing to know to determine if this is a valgus or varus deformity. And we take into consideration the MAD value, which is given in millimeters. Again, if you look at the Mikulicz line, or the mechanical axis, this axis is always going to determine a kind of reference for the joints. So if you have a tangent to the femoral condyles, to the tibial plateau, to the talus, all those lines that are tangent to those joints, they're going to determine angles in relationship to the mechanical axis. And those are the angles that you should take into consideration when you're doing correction of the lower limb in the coronal plane. Those were determined by Paley, and especially for the knee, which is the area that I operate most, I pay a lot of attention to the MPTA, which is the mechanical proximal tibial angle, and to the MLDFA, which is the mechanical lateral distal femur angle. Most of those angles are going to be very close to 90 degrees, meaning that the joints should be parallel to the floor in normal individuals. Again, those are the angles of reference that one has to take into consideration with the interval that is accepted to be okay. For the lateral distal femur angle, it goes in between 85 and 91, and mechanical proximal tibial angle, it goes from 84 to 90, and those angles are of critical importance if you're doing planning and if you aim to restore the alignment of the lower limb. The message number two of this presentation is: the mechanical axis of the limb is a critical line that has a relationship to the center of the knee that's going to determine the mechanical axis deviation into valgus or varus in cases of deformity. And the relationship of this line to the joint lines is going to give the orientation of the joints, or the joint orientation angles. Now let's see the preoperative digital planning. There are two supplements of the Journal of Knee Surgery that I had the opportunity to edit together with Dr. Lobenhofer in 2017, where you're going to find 14 articles that cover all kinds of preoperative planning for osteotomies around the knee. And this is a very, very interesting article that I do recommend you to have a look, because most of the things I'm going to present to you here are going to be detailed in this particular article from 2017 from Dr. Schroeter. So you may use different kinds of platforms for preoperative planning. You may use different softwares. You've seen here, and you're going to continue to see BoneSetter, which is an outstanding tool. You may use TraumaCAD, and the one I'm going to show you today is MedCAD, which is a German software. When you open MedCAD, this is the interface you're going to see. You may do all kinds of preoperative plannings for hip replacements, knee replacements, for trauma, for upper extremities, for spine. And what I normally use for lower limb deformity is the long leg. And then when I take the long leg, I'm going to show you, this is the first interface. You import the picture directly from the PACS system. or you can do a copy paste from a JPEG picture as well. In this case, you're going to do the right side. The first thing to do is to have a calibrated X-ray, a calibrated long leg standing X-ray, because then you're going to have a scale. You can use the spheres or a scale to measure and to have a kind of calibration of the X-rays. Then you determine the center of the hip, the greater trochanter, a tangent to the femoral condyles, a tangent to the tibial plateau, a tangent to the talus, and then the femoral axis, the tibial axis. And with all those lines that you have now, you already have the opportunity to determine the joint orientation angles for this particular side, and you have it automatically calculated by the software. And every angle which is red is abnormal angle. It's an angle that's not completely normal or is outside of that interval range that I just showed to you. And you're gonna know exactly where the deformity is by looking at those angles. If the deformity is in the proximal tibia, in the distal femur, distal tibia, proximal femur, or if it's extra-articular. This is how you can move those measurements to the side, and then you can calculate and do your drawings for your osteotomies as well. So always take into consideration the angles of reference. Now let's move to the left side. The patient had surgical procedure before, and you can see this patient has a valgus deformity, and the lateral distal femur angle after his fixation for the distal femur fracture was 81.2. So this tells you this is a red angle. This is not a normal angle. This is where the valgus is coming from the distal femur. Now comparing the right side, which is the normal side of the patient, with the left side, you can see the difference between MPTA, LDFA, and you can have a sense, even leg length, you can compare, and you can have a sense about what's going to happen if you do all kinds of corrections that could be open wedge, distal femur, or closing wedge, distal femur. And you're going to see how much does it going to impact the leg length. When you go for torsion, you're going to see that torsion is a very interesting deformity because you cannot really appreciate torsion very well with X-rays. You need CT scans to do that. And this is a typical torsional deformity. For torsion, you need computed tomography to evaluate the axial plane. And you have to measure this for the femur and for the tibia. With MedCAD, what you need 3 slides for the proximal femur, you need 2 slides for the tibia. So you take the hip joint center, the greater trochanter, the femoral condyles for the femur, the tibial plateau, the distal tibia for the tibia. And what you're gonna do, you're gonna overlay the 3 slices for the femur. And by doing that, you're going to determine the femoral head, the trochanter area, and then the posterior aspect of the femoral condyles, and then the software is going to give you exactly the torsion of the femur in this case. For the tibia is the same. You're going to overlay the tibial plateau with the distal tibia, and by doing that, you have a line that determines the posterior rim of the tibial plateau. You have the distal tibia, you have the tib fib, and then you have the axis between the tib fib and the distal tibia, and then you have the torsion of the tibia. You cannot measure the torsion of the tibia comparing measurements from tibia and femur. You have to have tibial plateau and distal tibia, not distal femur and distal tibia, because otherwise you miss the torsion of the tibia. To exemplify, this is a 21-year-old male. Main complaint is patellofemoral instability. He came for MPFL reconstruction to my clinic. He had this femur fracture before 3 years ago. He had no complaints about this fracture, but his symptoms started after the fracture. And then I measured, this is the case I showed you before, he had valgus, but he also had torsion. He had 20 degrees or 22 degrees of retroversion of the right femur. So then the final diagnosis for this individual using the software is he has 5.5 degrees of valgus alignment and 22 degrees of femoral neck retroversion. To correct that, we use the software to calculate exactly the angles and what kind of osteotomy we would do. And we ended up doing an open wedge lateral with 8 millimeters, and we did the torsion of 22 degrees in order to correct this deformity. And this is the patient after 6 weeks. This is the patient comparing before and after. This is 3 months. This is at 6 months, and this is after we remove the hardware. One of the problems with distal femoral osteotomies, we may talk about this in the future, is that lateral plates very often have to be removed because they cause a lot of friction to the IT band. And this is one of the reasons why currently we try as much as possible to go to the medial side, unless we cannot match the leg length discrepancy in those cases. Take-home messages about this presentation. Deformity analysis in the lower extremity should be based on very good quality long leg standing radiographs for the coronal alignment, computer tomography for axial alignment. The digital preoperative planning allows to identify the exact location of the deformity. If this is femur, if this is tibia, if this is in the joint, you can know exactly. And it gives you also a 3D perspective of the lower limb alignment. The digital preoperative planning requires precise long leg standing radiographs. Computer tomography adds significant information, and keep in mind the standard values for the joint orientation angle. So